I want to thank to Professor Sensi-Wan and all the organizers of this conference. And it's an honor for me to participate in this conference. I apologize for my poor English, and after the video, my son will help me with your questions. Thank you very much.
Good morning. I am Itziar Gotxi from the Basque Country, Spain, and I will speak about our experience in laryngeal electromyography guided vocal fold injections. To my left is Mónica Ortega. I work with her in the public hospital. She's a neurophysiologist at the Galdakao Usansolo Hospital. And to my right is Silvia Taramundi. I work with her in the private medicine in Medibilbao Salud. She is the head of neurophysiology service at Cruces University Hospital, close to Bilbao. We use laryngeal EMG to perform laryngeal injections because we can perform the injection of a temporary resorbable material such as hyaluronic acid into the paralyzed vocal cord in the same act in which we perform the neuropathy EMG diagnosis. Which conditions is considered as indication for this technique? For us, the main indication is the temporary medialization of the vocal cord in the early stage of unilateral vocal cord paralysis with glottic insufficiency because it allows us to perform the treatment in the same time that we do the neuropathy diagnosis. Other indications can be vocal cord atrophy or scarring treatment, presbyphonia treatment, or when we want to objectify medialization results before performing other less temporary medialization techniques such as thyroplasty or laryngoplasty with autologous fat, for example. What advantages does laryngeal EMG provide us in the management of vocal cord paralysis? This technique is performed in the office. Like it does not pass through the glottal light, the patient's tolerance will be better than techniques that are accessed through the glottal light. Ensures precise localization of target muscles, the thyroid muscle. It allows us to make a diagnosis and concomitant treatment. We'll be able to perform EMG assessment of neuropathic damage and medialization treatment in the same act. With low risk of complications, it has less morbidity, less time, and less cost than other techniques with general anesthesia. The disadvantages of this technique are that we can't see the EMG needle and the infiltration point. This leads difficulties when it comes to calculating the exact amount to inject, because we do by hurry. So we end up over-injection or under-injection of hyaluronic acid. But we can solve it with fibroscopic control. It allows us to see the bulging of the vocal cord, and we can calculate the amount to inject. Procedure overview. Patient preparation before technique, and they are instructed to take 5 milligrams of diazepam the night before and 1 hour before the procedure. And we use a lidocaine and prelucaine cream on the skin of the anterior cervical area. When we use fibroscopic control, we will apply nasal and pharyngeal topical anesthesia. The needles that we use for the injection are 50 millimeters long and 26G monopolar needle adaptable to syringe. The hyaluronic acid that we use is the Restylane leaf. Restylane leaf is non-animal established hyaluronic acid filler, which is biodegradable and biocompatible and has a concentration of 20 milligrams per milliliter of hyaluronic acid. It is one of the thicker formulations in the Restylane family of fillers, designed for more robust volume restoration. Now I will show you a video of the technique.
As I have explained, we will proceed to administer topical anesthesia with lidocaine in the oral and nasal cavity prior to performing nasofibroscopy examination. We will also have previously put a cream with lidocaine on the anterior cervical skin. First of all, we will carry out the electromyographic study of the nerve injury, and later, after performing the pertinent maneuvers to activate the thyroid muscle, such as the phonation of a sustained vowel like the I, and knowing that we are in the motor plate, we will proceed to infiltrate the material, in our case, hyaluronic acid. When we are not sure of being in the correct spot, we will reposition the needle until we are sure of infiltrating the thyroid muscle. We will monitor for bulging of the vocal cord or extravasation of material posterior to the arytenoid or ventricular band. We do not bend the needle, so this allows us to use finer needles with a diameter of 26 G. When we finish the injection, we will check the closure and if there are any complications.
Our results in 52 people with unilateral vocal cord paralysis and neuropathy with axonematic damage are the following. We performed the injection before 3 months after the start of the clinic in 66.67%, between 4 and 6 months after the start of clinic in 13.33%, and between 6 and 12 months after the start of clinic in 19.99%. In the follow-up to 12 months, 73.08% have only one treatment, and 26.92% have second treatment up to 12 months. If we analyze voice outcome indicators, a statistically significant improvement was observed in the evolution of voice handicap index values up to 1 year after treatment. This improvement was more pronounced during the first month after treatment and subsequently maintained a smaller decreasing trend until practically reaching a plateau between 6 and 12 months. A statistically significant increase in the evolution of maximum phonation time was observed up to 1 year after treatment, being more pronounced during the first month after treatment with an increase in the maximum phonation time value of 77.12%. The maximum phonation time rises from 5.42 seconds to 9.60 seconds after treatment. The evolution of the GRAVE BS scale values is similar in all diagnostic groups in the assessment carried out 1 month after treatment, and a significant decrease in the GRABS score can be observed. The complications we objected were 1 case of vocal cord hematoma, 1.92%, and 1 case of arytenoid mucosa and ariepiglottic fold edema, 1.92%. And as a conclusions, we can say that laryngeal EMG guided vocal fold injection is a safe technique with a low morbidity. Laryngoplasty by hyaluronic acid injection with EMG guidance, performing in the early stage of unilateral vocal cord paralysis, achieves a satisfactory position of the vocal folds and functional improvement. A significant improvement is observed in the evolution of voice handicap index, maximum phonation time, GRBAS values up to 12 months of follow-up. Thank you very much for your attention. And this is a picture of a great place that I like very much, close to my town, where you can see San Juan de Gaztelugatxe. Thank you very much.
Thank you, Dr. Gotxi Erezuma. Is there any question from the floor?
Thank you, Itziar. I'm Dr. Wang. Thank you for your excellent speech. And I think it's also a good way to combine the laryngeal EMG with flexible scope guidance injection that can practice the skill of laryngeal EMG. And in my experience of the laryngeal electromyography, I usually my cell phone, put my cell phone away from the laryngeal EMG machine, because some electrical signal probably will interfere the EMG machine. Have you ever encountered that kind of problem when you use the flexible laryngoscope? Because there is also some electricity through the laryngoscope machine, very close to the EMG machine. Did you have that kind of situation happen during your practice?
Yes, I have in some time. Yeah, it happens. But then we change the cable and it goes well.
Thank you. So Amanda, I would like to ask Amanda, did you do any EMG in a spatial room? Because there are so many electrical signal nowadays. Everybody use cell phone, or so. Did you do your EMG in a specific room?
My EMGs are done in the voice clinic, and they're right beside the audiology suites. And the audiology suites are all soundproof, so that does help. I actually had a few patients with pacemakers, and actually you can hear it on the EMG machine. It's like a clock ticking. So I just have to be careful just to ignore the ticking clock.
Thank you. And Itziar, before I use the wrestling lift, or we call it wrestling plane in Taiwan, different brand name, but probably the same product. Before that, this is a medium-size hyaluronic acid product with a medium-sized particle. So we can inject it with a 26 gauge needle. Have you ever used any bigger molecular hyaluronic acid with a bigger needle? Or in the first beginning, I inject the wrestling with a smaller molecular, but the outcome is not long lasting. So I start to try plane. Yeah, because the wrestling, they have a different product. I don't know, do you have any common on this product?
I use also Restylane, but I have the most product that I use is Restylane Lift. Yeah. At first, I become using Restylane, and then I continue using Restylane Lift. And I never use another size of needle. We always use 26G needle, and it was really good.
Thank you. We have attended Professor Zhou. 周永恩，你是不是有用过更大分子的？Have you ever used any bigger size molecular hyaluronic acid? Could you give us some suggestion or your experience sharing?
It is from the cosmetic department. They use the larger molecular hyaluronic acid, but I think that there's no difference concerned about because my I think that the compensation, early rehabilitation is the most important for this procedure. Yeah, but I think that the repeated one who needs a repeated injection 2 times or 3 times, I suggest them to receive the thyroplasty surgery. So I think the hyaluronic acid is absorbable, and the time limit is maybe 2 more months or 3 more months. It's nothing big difference. Yeah.
Thank you, Dr. Gotxi. It's really early in the morning in Spain. So do you have any tip for the junior doctors to learn about this seemingly simple technique? Because when I was a junior trainee, it took me some time to put the needle into the right place, and the patient wasn't very happy about that. Do you have any tip for the junior doctors?
Well, I think first of all, they have to practice with, we made 3D laryngeals, and I think it's a good way to practice before to do the procedure in a person. So we can start practicing with 3D larynx. Yeah, I think it's a good tip.
Oh, that's good to have the 3D model for practice beforehand. Yes, please.
Yeah, I want to ask about the laryngeal EMG signal, because sometimes when I put the needle inside, very shallow, and we can have the spiking fibrillation signal. So do you think that how depth of the needle come in, and the signal with the fibrillation or the decreased recruitment, yeah, that's the point we inject, because sometimes I put a needle inside and only very shallow, and the signal coming out, so I dare not inject. So I always use the scope to confirm. Yeah, so because you do a lot of LEMG, you have a lot of experience. Can you tell me, do you have this kind of experience about this? Thank you.
Okay, I don't inject the paralysis vocal muscle if okay, sometimes you don't find fibrillations potentials, like you say, that they are very low, and if you have a lot of recruitment reduction, I use the scope to see, and and sometimes maybe you are not sure that you are in the place, but in my experience, le quiero decir que, a ver, cuando hay disminuidas las potenciales de, o sea, la fibrilación y tal, que a veces no te vas a quedar seguro de que estás ahí. Cuando tienes mucha experiencia, al final, bueno, pues sabes que estás ahí y lo que haces es confirmarlo también con el fibroscopio. ¿Lo puedes decir tú, por favor?
Yeah.
My son will answer this question because it's a little bit difficult for me.
Yeah, so she's saying that when the fibrillations are low, she uses the help of the fibroscopic.
Bueno, que haga un control con fibroscopio para ver fibroscopy.
Okay, that she does the control by using the fibroscopy, but that at the end of the day, while doing more cases and with more practice, that she's more sure about that she's in the right spot, so she can trust herself.
I think I can assist to answer this question. If you feel because the depth of the needle depend on the different anatomy of the patient. If the patient is very skinny, you don't have to puncture too deep because the TA muscle is very close to the skin. And if you want to make sure the needle tip is in the TA muscle, not in the straight muscle, when the patient keeps silent, you can ask the patient to do chin up and chin down because that will move the straight muscle. If we see any recruitment when the patient performs this task, that means the needle tip is in the straight muscle. So you cannot do the injection. You need to push the needle deeper. But if there's no signal when the patient do the chin up, chin down maneuver, that means the needle is in the right place. Don't worry. But if you puncture the needle into the airway, you will not find any fibrillation signal or any normal motor unit recruitment. You can only listen to this kind of sound, just like a patient is using the microphone to speak in E. So that means the needle is in the airway. So not difficult, but because of the time limitation, I cannot explain every detail of the technique of the laryngeal EMG. But hopefully we can work together to organize a workshop of the laryngeal EMG in the future. We can spend longer time to discuss, exchange every detailed experience in the future. And thank you, Itzia. Yeah, thank you for getting up so early and deliver the lecture. Thank you so much.
Thank you very much for inviting me to this conference. It has been an honor for me to participate. Thank you very much.